You're watching Docs on Call with Dr. Chris Stroud from Northeast OBGYN answering your questions on infertility. Doctor, as you talk, I'm very aware that infertility is not only emotionally driven but also time-consuming for these couples. It seems like many of them have to go through many tests. How long does it take, and what kind of burden is that on couples?
Sure, I think that's an excellent question. You know, in the overwhelming majority of cases, we can get information very quickly. Now, unfortunately, it takes a few cycles to get that information. So we may have to go through 2 or 3 cycles to better understand a woman's ovulatory schedule, you might say, and we may have to do a few tests that can only be done at certain times of the cycle. But I would say in the majority of cases, within 3 cycles, we can put together a puzzle that either directs us in one direction or in another.
All right. We have Jason on the phone. Jason, what's your question for Dr. Stroud?
Yes, I had a question. My girlfriend had a tubal ligation done 2 years ago, and she was wondering what her chances of becoming pregnant, and if they weren't that great, what would be the best place to go to have a reversal, or if that would even be worth pursuing?
Certainly a good and important question. If I understood you correctly, you said your significant other had her tubes tied, and now you'd like to know what's the probability of her becoming pregnant without doing anything. Is that correct?
That is correct.
Yeah, we tend to quote a pregnancy rate after having one's tubes tied of about 1 per 1,000. To help put that in perspective, the pregnancy rate on the birth control pill is about 1 in 100. So it's not unheard of to become pregnant after having your tubes tied, but it's very unlikely. As you also mentioned, it's possible to have the tubes re-anastomosed or put back together after having them tied. That's a difficult operation. It is done. It's typically done by a subspecialist in obstetrics and gynecology known as a reproductive endocrinologist, and it can be done. There's certainly a great deal of information that has to go into advising a woman and her partner on whether that's the appropriate way to go versus other forms of reproductive assisted technologies. I think we'll be showing our email address, and I'd certainly be happy to help guide you and your significant other. If you'd like to send me an email, be happy to do that.
What are the
Alrighty, thank you very much.
Thank you, Jason. What are the chances of pregnancy after a reversal of tubes being tied?
Yeah, that's a good question, and it's a difficult one to answer because keep in mind the natural pregnancy rate is only about 20% per cycle. So that's as good as it gets naturally. So we can only expect to get that good with any of the assisted technologies. It really depends on how long the tubes have been tied. The longer the period that's gone by since the tubes were tied, the less the probability of conceiving after having them put back together. It depends to some degree on what method was used for the tubal ligation, and there's a great deal more that goes into determining that question. But it's something that we have to help patients think through before they decide if that's the right choice for them, because there are others.
And you do help a lot in the thinking through process.
That's part of our job.
Good.
That's right.
Ashley has a question for you. Go ahead, Ashley.
Yes. Me and my husband have been trying to have a baby for over a year now, and I have always had problems with my ovulation and all that ever since I started my period. And it seems like whatever we do, I try to time ovulation and every month, but sometimes I'll skip months at a time, and it's just not working. We're not getting pregnant, and it's kind of frustrating. I'm wondering what can we do and what else how can we try that we haven't.
Sure, great question, and thanks for calling. One of the common interventions that we make in the circumstances that you're describing are medications that will help ovulation. Not only do they help ovulation, but they help increase the likelihood of it being at the predictable time. One of the common interventions we do is an ovulation medicine. Then we'll do ultrasounds beginning sometimes around day 11, 12, and 13 to see if the follicle is developing. Sometimes then we'll give an injection of a medication that increases the likelihood that ovulation will occur within the next 24 hours. And then we follow that with timed intercourse. So from what you're describing, the next logical steps may be taking a more aggressive approach at managing the cycles, managing ovulation, and managing timed intercourse. And that's something you should really sit down and talk to whoever is helping you work through this.
Does that answer your
well, thank you.
Thank you,
Thank
Ashley.
you, and good luck.
Up next is Stephanie. Stephanie, your question for Dr. Stroud.
Hi, Dr. Stroud.
Hi.
I suffered from 5 miscarriages after having 5 successful normal births, and I researched online a lot about the thyroid, and after my 5th miscarriage, they did testing, and they said that my thyroid level was normal. However, when I went to a reproductive endocrinologist later on, he would say that that level is not normal for some women, given the circumstances of what I was feeling, you know, the tiredness or the headaches or the, you know, the symptoms of thyroid problems.
Certainly.
What is a level for an OBGYN considered normal compared to my endocrinologist?
Sure, that's a good question, and it probably speaks more to your physician's comfort level in managing subfertility or infertility than it does an actual lab test. And by that I mean the normal thyroid level for those of us in the average population walking around may not be the level that's necessary to get regular and predictable ovulation. There is a body of literature that describes the so-called low normal, meaning that the thyroid level falls within the normal range for the average population, but in the subfertile female population, that may not reflect the necessary level to produce regular and predictable ovulation. So I can't give you an exact number because it depends on a fair amount of specifics to the circumstance, but what your reproductive endocrinologist is telling you is very commonly discussed in the infertility work.
How are her miscarriages tied to her ability to get pregnant?
Yeah, what a devastating story.
Yes.
I mean, 5 miscarriages. I mean, the good news there is that she had miscarriages after having 5 normal pregnancies. That certainly puts that caller in a different category than the woman who's never been able to conceive and carry to term. Nonetheless, can you imagine how dramatic and devastating 5 miscarriages must be? We could probably do an entire evening just on recurrent miscarriage, but it's certainly something that has to be evaluated. It needs to be evaluated by someone that's comfortable and experienced in dealing with what we call habitual pregnancy loss.
Thank you. Kristen, you have a call. You have a question for Dr. Stroud.
Yes, I was calling on behalf of a friend. She had a normal pregnancy approximately 4.5 years ago. She carried full term. They had told her actually before she became pregnant that she was would not be able to carry full term because of the shape of her pelvis and uterus and whatnot. Everything went normal with that, but since then they've been trying for a few years and they have not been able to conceive. And I'm just wondering if the diagnosis of the abnormal uterus or pelvis is even accurate for her, because she did carry full term and had a normal pregnancy. I'm wondering if that has anything to do with why they're having trouble now.
Yeah, thank you for your call. I think that's a good question. There's actually 2 answers there that I think are important. One is, if more than 6 months or 12 months have gone by, depending on your age, regardless of the fact that a woman has conceived in the past, she should still consider that as a problem, and it needs to be evaluated quickly. The other one is this idea, was there a problem with the pelvis or a problem with the uterus? Those are really separate things. If there's a problem with the uterus, that certainly could be the problem in this case, but it should be evaluated, or maybe in your friend's case it should be reevaluated. I hope that helps.
Right. Okay.
Thank
Yes,
you.
and I did. I would like to comment also. My husband and I had tried for about a year, and I did have a very stressful, demanding, overbearing job, and I had switched departments, and within the 3 to 4 weeks of changing job responsibilities and the stress level going down, we conceived. So I really do think that has a lot to do with the ability to conceive naturally, with our experience anyway.
I think it's fair to say we can't underestimate the impact of our work life and stress levels in all of our health, not just our fertility.
Yes, and Sarah, let's see, Sarah has a question on the most fertile years. Sarah, quickly go through your question.
I was wondering, if you're on your period for about 3 months, will that affect you getting fertile or having kids later on in the future?
Sure. The fact that you're bleeding for 3 or 4 months is not the problem. I mean, not the problem in terms of getting pregnant. If you're bleeding like that, it means by definition that you're not ovulating. And not ovulating is what's preventing the pregnancy.
Okay. Thank you, Sierra. That's a very good question. We have about 1.5 minutes left. What do you want our viewers to take away from this?
Yeah, I think, Elizabeth, there's a couple of important things. Probably first and foremost, this can't rule or ruin a couple's life. It's important, it can be devastating. At the same time, we have to approach it with a sense of calm and a sense of faith that it's going to work out in the overwhelming majority of cases. The other thing we have to think about at the same time is that time can be the enemy. And I think there is a tendency to be quiet about this and to just hope that eventually it will get better. And in that case, we need to be more aggressive. So talk to your physician about these problems. There's many, many things that we can do to help this, and the overwhelming majority of couples will go on to conceive, sometimes with a little help.
And you are so personally involved that you want people to write you or call you and email you and give us your address.
Certainly. It's, I believe we've shown it before. It's Christopher.Stroud@parkview.com. Be happy to entertain and respond to any of your questions that you didn't get a chance to answer tonight.
Thank you very much, Doctor, for being here. We've learned a lot. I've learned a lot. And thank you very much. Dr. Chris Stroud from Northeast OBGYN has been my guest tonight. Thank you for joining us and for Docs on Call. Tune in Tuesday night. Lee Kelso will be here with Pain Management and Associates taking your questions about nerve pain. Join us next week. Good evening.